Hello, Dr. Hampton here. Welcome to our post-podcast session. We just recorded episode number 10, and next to me is Dr. Feinman, who was my guest, and I'm going to introduce him to this audience on YouTube and Facebook. So excited to have him. During the podcast, we talked about nutrition, metabolic health, the carnivore diet, and even cancer. We touched on a lot of different topics. I think you'll find it interesting. And he's an expert on metabolic disease and nutrition as a biochemist. And I wanted him to share those talking points. But I wanted him to come to YouTube and Facebook to talk a little bit about another topic, and that's a critical look at the medical literature. And we're gonna do a little bit of a slideshow. He is a professor, so we're gonna take you to school and we're going to learn a different perspective about how the medical literature should be viewed from a different perspective. Dr. David Feinman, Richard David Feinman, is a professor of cell biology and biochemistry. And I'm very fond of biochemistry because I'm actually having to study that in my nutrition master's class as well. Because a lot of the things that we talk about with diabetes and metabolic disease is all about biochemistry. So we really want experts in that field to kind of guide us as we think about this topic. He got his training at State University of New York, and we love New York, in Downstate Medical Center in Brooklyn, New York. His original work was in protein chemistry and enzyme mechanism, particularly in blood coagulation and related processes. He did work on several scientific areas, including animal behavior, believe it or not. And he previously did work in the visual art, life in the visual art space. So that's very interesting. He is a principal author of a 26-author comprehensive review called Dietary Carbohydrate Restriction as the First Approach in Diabetic Management, a critical review. That's evidence-based. And to be honest with you, you want to listen to that podcast. That'll be released this coming Friday, as always, the following week. And I just think that's something you really want to look at, particularly if you're a diabetic or you're at risk for that, which is so many people. He did have a book entitled World Turned Upside Down, Second Low Carb Revolution. And I think there's going to be a second updated version about that, which he could speak to. And so he's really an incredible guy, very knowledgeable. And again, my job as your, virtual doctor, giving you information is to bring people aboard who can help guide us. So having said all of that, I want to get my buddy to chime in here. And I want him to kind of introduce himself. Just introduce yourself to the audience and let them know who you are, just in general terms.
Well, I think you covered most of my life. The book is in the second edition. It is now called Nutrition in Crisis, and is now in print in Germany as if you want to read German. I recommend buying it now because I think the publisher is trying to unload it, and you can buy it for very cheap. I'm going to send Tony the information. And my current research is in ketogenic diets for cancer. And I work with Dr. Eugene Fine at Einstein College of Medicine. And we're making progress. And my general feeling on ketogenic diets in cancer is optimism, although we have a long way to go.
Yeah, and I appreciate that. I just did a live session yesterday, I mentioned, and we talked about our fallen hero, our Black Panther, and I just wanted to remind people about all the things that they need to know about colon cancer. So I appreciate anybody who's doing research that will give us some additional tools to help as we fight this cancer battle, which is probably the second leading cause of death behind heart disease, and stroke's right up there as well. So I appreciate that. I do want to ask you, because I think about the Black Panther and what he represented, and we have underrepresentation of Latin American, you could argue Asian, Indian superheroes. There's underrepresentation. But I know you work in New York, and in the urban sprawl, you probably have a very diverse population of people. And I'm curious, what's been your experience in terms of working with a community of color and your ability to impact that community, rather is through your research or just in any way that you'd like to speak to?
Well, my experience is very limited, but Downstate Medical Center is not only a center for the diabetes epidemic, but health disparities. And my limited experience was applying for a grant at AHRQ, which is the subset of Health and Human Services, sort of parallel to the NIH. And we wanted to treat 200 African Americans with type 2 diabetes with a low carb diet. And the PI was actually the head of family medicine at Downstate, who's well known and expert. We got very discouraging response. In fact, despite the fact that we called in advance and said, this is a controversial area, we're going to get a fair shake here, I don't think they even read the application.
What's controversial about doing a low carb diet on African Americans? What's the controversy? Is it the low carb part or the African American?
Yeah, well, that's the problem. It's the low carb part. It's my experience, again limited, but my general impression is that the health agencies have a very serious commitment to health disparity, and it's their inability to focus on the science that's keeping them back. And it's it really is a kind of inadvertent prejudice, but it's real. And I think it's very discouraging. I think it's changing. I mean, I think we wouldn't have guessed that the barrier was the science, but it is. And I think they're recognizing that they can't keep doing the same low-fat stuff and getting the same minuscule effects, and continuing to rely absolutely on drugs and having side effects. And so I think it's changing.
Yeah.
And as I say, the optimistic part is there is a commitment, I think, to dealing with health disparities.
Okay. Well, I'm definitely a huge fan of health disparities. Obviously, I grew up in a neighborhood on the West Side. In fact, I think anybody who had not seen my post about the Diet Doctor, they did a feature article, and I talked in that article about just growing up, what it took to get from A to B. But I do think that we need people like yourself who will be willing to do the research, people like myself who's trying to engage this population on a different way of looking at health as opposed to disease management, moving towards a model of wellness and prevention and healing. And I think that's a better model. Although we want to take advantage of technology, I wouldn't want somebody I know we touched on cancer, but I wouldn't want somebody to not benefit from cancer treatment. But I also want them to understand that you want to create a vessel for that's uninhabitable for cancer, and you can do that through your diet. So I just want people to hear that. But I'm going to punt towards what we want to talk about a little bit today, and that's the medical literature. So I'll do my best to share my screen now. And when I do that, I'm going to make sure that I pull up your slides that you shared. And I really appreciate you doing that, because I think my audience needs to understand fully, you know, what it is that, how to interpret the literature. So the title of your presentation, and I'll advance the slides for you, is What's Really Wrong with Medical Research and How to Fix It. So I'll kind of let you drive the ship from here, and I'll advance the slides, and we'll go from there. Any comments on this slide before we move on?
That's accurate.
Okay. Amen to that. So, and again, students in the audience, because when I finished this presentation with the doctor, the great professor, he told me to call him Richard, but I'm struggling to call him Richard. But Richard, the PhD.
Well, I did. There is a famous physicist named Richard Feinman, and I had started using my middle name, Richard David Feinman, to.
I did. When I pulled your name up, literally, I struggled to get his name out the way.
Yeah, well, it's so it was suggested I use my middle name to distinguish myself. It hasn't done much good, and I'm planning on changing my name to Richard DeGrasse Feinman.
Wow, that's amazing. Isn't that crazy? That's the world we live in. I have a very common name too, but fortunately, there hasn't been any people in my space that I'm competing with. So, we'll throw all my followers. Please just throw out a little prayer for my friend here, so he can get his name out there. And I think it'll start with the information we share today. So let's get started on this topic of medical research, and well, let's go ahead and comment on what we have in front of us.
Okay, so it's got a problem. Now, I've been a critic for a long time of the medical literature. It is afflicted by studies with small sample sizes, invalid exploratory analyses, flagrant conflicts of interest, and in addition, you can advance that. Scientists too often sculpt data to fit their preferred theory of the world. I mean, that is a problem, that we're not distinguishing between opinion and. The point is, though, that although I've been a critic for a long time, I would never say stuff like this in print. This actually comes from Richard Horton. He's the editor. You can go to the next build here. He's the editor-in-chief of The Lancet.
Gotcha.
And that's pretty scary.
That's pretty amazing that he would make these type of comments.
Well, he's supposed to be what they call the gatekeeper.
Right.
Where when this went bad.
Wow.
The next slide is where this came from. It came from a. You can go ahead on this. Next. This symposium that was held in London, and it was, secret, but they published a report. The report actually was much longer and much more graphic pleasing, but it didn't say any more than this. And the next thing is, already this tells you a little bit the problem. The case against science is straightforward. It's not science, it's medicine. And he's already changed the, changed the playing field. And this is already indicative of what's going on. There's a lack of precision here.
Wow.
And he's not the only one. This is from Johnny Anides, who's a well-known critic also. And the detail of that says, next, you want to go next one? Oh, yeah. So this is that a PPV, that just means, you wanted to show the next one? Yeah, it's a positive predictive value. Basically, that's telling you how what the probability is that their conclusion is right, and that the conclusion is right is only 50%. And in fact, as he says, you don't even get 50%.
50%. That's horrible.
Yeah. The next slide is, so what went wrong? Who's to blame? Now, we need to know, the literature has 50% errors. Is that okay?
It doesn't sound, I mean, I think as a doc, I would assume that it would be a much lower error rate.
Well, the thing is, the next line is what 50% is not reproducible. Is that okay?
No, it's not. But I thought that when you're trying to evaluate the quality of a study, it had to be reproducible, which would then make it, something that we could trust. And you're saying that 50% not reproducible? That doesn't even make sense.
The next line also. So this is the problem. Well, by 50% reproducible, they mean that if you do a study and you come to this conclusion, half the time nobody else can reproduce it. I'm going to tell you a joke about this.
All right.
So a guy goes to the produce store and he tells the clerk he wants to buy half a head of lettuce. The clerk says, I can't sell you half a head of lettuce. And the customer says, sure you can. Go ask your manager. So he goes in the back to ask the manager. He doesn't notice that the customer is following him into the back. He says to the manager, there's some jerk out there wants to buy half a head of lettuce.
Yeah.
And then he sees the customer and he says, and this gentleman would like to buy the other half. So that's the problem. Okay.
That's funny. And thankfully he was thinking on his toes. He's a good employee.
Well, when you say 50% error and you don't name names,
that's right.
Assumes it's the other guy, that their stuff is just fine. And that's the problem, is that we're just continuing in
it's a little bit of a herd mentality. So we're just following something that's clearly
we're agreeing to it because it's the system.
Yeah, it's just a system.
So here's one of the problems, and that's statistics. It's widely quoted that and attributed to a lot of people that there are lies, damn lies, in statistics. And the problem is that you can't rely on statistics as your master. You have to make sure it's doing the work for you.
Wow.
So I'm going to run through this slide. I'll just say next for each line, because all I wanted to do here is tell people the thing you'll see in the literature, and that is next. Next line. So when in the medical literature, when they talk about risk, they mean probability. And next shows you what probability is. You know that probability is the number of times you win versus the number divided by the number of times you play. Okay. So if you make 10 plays and you hit it 5 times, you're probably winning is 50%.
That's right.
And so they talk about risk, and so 120 people develop cancer, then they out of 1,000, that's 12%. The next thing is relative risk. Means what it sounds like. If you have a risk in one population and you divide it by the risk in the other population, that tells you the relative risk.
Okay.
And there's a problem with that. It's a percent difference. It's hiding information.
Right.
Show me the next line. I think that tells you. So if Alice has 30% more money than Bob, they may both be on welfare, or they
Right.
may both be billionaires.
Right.
And that's the problem.
That's
Because
right.
if a treatment has 30% better outcome, and you see that in the popular literature all the time, you don't know whether there were 10 people in the study or 10 million.
That's right.
Okay, so now another thing, here I just want your viewers to get a sense of the language. Next thing is shows you, the next line is, so remember that risk is the number of wins versus the total number of plays. Sometimes they talk about odds. And the
Yeah.
odds are the number of wins divided by the number of losses.
Yeah.
Now, so they talk about odds. However, if you had the same 1,000 people, the odds would be 120 divided by 880. Those are the people who didn't win. So they're almost the same if you don't have too many plays,
That's right.
And that's what I want people to understand. That what you'll see in the literature might be odds ratio, relative risk,
Right.
also hazard ratio. Now, hazard is similar, but there's a time component. The important thing, though, is that as it's done, if there are not many cases, and the time does not go out, 25 years, then all these things are the same. So that's the only take-home point on these two slides.
Gotcha.
So the relative risk is the risk of the intervention versus the risk of the controls. Odds ratio is the odds of the intervention versus the odds of the control, and hazard ratio is the same thing. So
Okay.
the take-home message here is only RR, OR, HR. That's what you see in the literature. It means the same thing. It means how good the intervention was compared to the control. And if those numbers are 1, it means there's no difference. Okay, so if you read a paper and it says the odds ratio is 1, that's nothing. Okay,
Yeah.
it means that the patient didn't do any better on the intervention than did on the control.
And I want to say to those who are listening, some people are, have varying levels of education, may have not seen any of these numbers or these definitions. I want to say you can always go back and look at it again, but the big picture is what as we kind of talk about this topic, is the big picture is why we have discrepancies in common sense, like I shouldn't eat starch and sugar if I'm diabetic, versus, and the literature supports that, right? But why is it that people are still recommending a low-fat diet to a diabetic? It doesn't really make sense. So the point of this is to give you a sense of how we see things as scientists and doctors, et cetera, and just get a feel for the confusion that's being created by this. So go ahead. I just wanted to make those comments.
The thing that I'm trying to bring out there is that it's written as an abbreviation ORRR, but we know this. There's hardly a person who has never gambled in their life, and you know what the odds are at the blackjack table, or you know that they're not stacked in your favor. And if the odds are 1 to 1, it's just a random outcome. Now, the question is, what would it take to prove to you that a drug is effective? Okay. And because what you do in a lot of the studies you see in the literature are a analysis of a study that's already been done, or it's prospective. They're doing a study and they're looking at the outcome. Mm-hmm. And what you're interested in is how good the intervention is compared to the control. Now, Bradford Hill, Bradford Hill is sort of the field is called epidemiology, and Bradford Hill is sort of the father of modern epidemiology. He did the study on cigarette smoking and lung cancer, and he essentially proved the point that it was unlikely that there was any doubt that cigarette smoking caused lung cancer. And so in this presidential address, which I don't know where it's from, but it's not hard to find by Googling it. It's available. It's very interesting. If you're interested in the philosophy of medicine, it's very clear. It's very sensible. And he laid down 9 principles of when you can say that you've really found causality. In other words, people say that association does not imply causality. And that's not quite right. Association does not necessarily imply causality. You can go on the internet and find all kinds of jokes about, how the number of people drowning in Maine correlates with the number of baseball games.
Right. That's right.
So, but the question is, sometimes they do correlate. And certainly there's little doubt that if you start smoking cigarettes, you're putting yourself at risk.
That's right.
So he gave these principles. I'll touch on a couple of them.
Okay.
Let's go ahead on this. That's Hill. Next. Okay, so he's saying that if event B is associated with the environmental feature, for example, respiratory illness is associated with dust in the environment. In what circumstance can we pass from this observed association to a verdict of causation? Now you can see that this is the kind of thing that you do in what's called a toxic tort case in law. Okay, the client claims that he got sick because of the all of the chemicals in the environment. And here you might try an epidemiologic experiment. For example, you would get all the people who worked in the factory and see how often they got cancer. And you would compare that to, say, all the people who worked next door at the offices of the same company. So the question is, with that data, what basis should we proceed to do so? Meaning infer causality.
Okay.
So the first thing he said is the strength of the association. And next. So here's the. Let me give you the story here. This was described in Siddhartha Banerjee's book, The Emperor of All Maladies, which is one of the great history of science and medicine books. Anyway, what they did is they were testing the idea that cigarette smoking was associated with lung cancer. So the way they did the study is they did snail mailing to doctors. Doctors tended to answer these kinds of polls, and then they tracked these doctors and got whatever information they could on their health and when they died. So as it says, 789 deaths were reported. Richard Dahl was Hill's assistant here. Now, they had 36 of these were attributed to lung cancer.
Okay.
When they tried to ask which of these lung cancers were in smokers, all of them were smokers. So there's not a lot of room for doubt there.
Right.
Okay. What's interesting and quite relevant is Dahl did not believe that was true. He thought that cancer was caused by effect of the atmosphere on asphalt from laying highways.
So even after getting this clear information, he's
No, not
still
after. Soon as he saw this, he stopped smoking.
gotcha. Okay.
He was a smoker, and when he saw the number of deaths, but that that's not a bad requirement for doing research. If you don't believe it and you're trying to prove it, and then you accept your results, that's what we call science, actually.
That's right. Okay, cool.
So this was their. Let me stop here and say. That was the criterion. Now, what he said, Hill pointed out that the odds of getting, or the odds ratio of getting lung cancer if you were a smoker was 20-1 compared to non-smoker.
Oh, wow.
If you were a heavy smoker, it was 30-1.
Mm.
Okay, so that's a widely quoted number of 20, and in this paper, he said that he wasn't sure about cigarette smoking and heart disease, where he could only get 2-1.
Mm-hmm.
And of course, we know that it is good data, and it's probably better than 2-1, depending on how you do the experiment. What's important is that in a toxic tort case, if you go in and you say that your client got cancer because of the whatever was in the air in the factory, it's very unlikely it would be admitted into evidence if it's less than 2-1.
Mm.
Okay, I mean, there's no absolute on this. 2-1 is convincing. I mean, if you've collected a sample of poisonous stuff, maybe you can come in with less than that. So
what's this statistically significant? I mean, is 2-1 or better where we cut the line?
That's a very good question. Statistically significant means that if you take all the data from the experiment, if you do a calculation, this is mathematical, what are the chances that those numbers came by chance? Again, if you want, right, you can have a computer run it by chance. And then there's a threshold, typically 2% or 5%. And then that means that it's very unlikely that that data arose by chance. It does not mean that if you did the experiment again, you get the same result.
Right.
It doesn't mean that it matters. It doesn't matter that your correlation of TV sets and heart disease means anything. It just means that it didn't happen by chance. And well, how could it not happen by chance? Well, the population became richer, and they bought more TV sets, and they ate more crap, and they got heart disease.
Right.
Okay, so it's very important to understand that statistical significance is not biological significance.
Right.
2-1 makes it more plausible, but it doesn't guarantee anything. So let's look now at this study of. This is really the backbone of the Mediterranean diet. Now, the Mediterranean diet has become very popular. Nobody really knows what it means, but because it's not excessively low fat, it's considered some kind of an advance. You have the impression that you are supposed to pour olive oil on everything. But it's big on fruits and vegetables and low on the meat, especially red meat. Unlike the stuff that I ate in Greece, and I've never been in Crete, which is kind of a standard for Mediterranean diet, but I did eat in a Cretan restaurant in Rome, which had a really good slab of meat that probably wouldn't fit in the Mediterranean diet. Anyway, you get the idea. It's telling you that you want to be fruits and vegetables and olive oil and nuts.
Yep.
Okay, so this is this is the most widely cited paper in New England Journal of Medicine from that year.
Gotcha.
So let's look at the data. So among people at high risk, Mediterranean diet supplemented with extra virgin olive oil or nuts reduced the incidence of major cardiovascular events. Okay, that's pretty impressive.
Yeah.
Let's look at the next line. This may be a duplicate slide. Anyway. Okay, here's the data. Now, it was reported in the literature that the intervention, the Mediterranean diet, was 30% better than whatever the controls were. The control diet. The control diet, I think, was actually a low-fat diet.
Mm-hmm.
So if you look at this picture, look at the inset up in the right-hand corner.
Mm-hmm.
That looks pretty impressive.
Right.
So now, what this is about is your viewers may not be scientists.
Mm-hmm.
The problem is these days, they may wind up looking at the scientific literature because the drug they're on, the drug company has this picture, or somebody selling it. So you got to ask yourself, eyeballing this, it looks pretty good.
Yep. And by the way, just so for those who are not as used to looking at this incidence of cardiovascular, composite cardiovascular. So you don't want to be high on this graph. So the control diet has a higher value. In other words, a higher incidence of cardiovascular than the Mediterranean diet. I just want to point that out, that we have to look at this part of the graph to understand what we're measuring. So you don't want to be up here. You want to be down here.
Yeah. But is that true? Well, if you look at the y-axis on that graph,
Mm-hmm.
those numbers are very small.
Yeah.
So these guys, nobody's getting sick very often.
Wow. That's true.
Okay. And what the main graph is a very honest reproduction of what you're really looking at. Look at all those lines. They're all the same, really.
Yeah. Yeah.
Now, the arrow now shows you what the actual difference is.
Right.
Not the relative difference, but the actual difference.
Wow. That's it.
0.02. So it's a 2% difference. Well, now the question is, what does that mean?
Right.
What it means, for example, if you did a vaccine study. Well, the vaccine study, 2% could be a lot. And not only that, you know who got the vaccine and who didn't. Therefore, you can guess that if you scale it up, it's going to pay off in the population.
Right.
But in Mediterranean diet, you don't really know what people ate.
Right.
Yeah. They don't even know what they ate.
Right.
I mean, as an experimental example, how much chicken did you eat last week, Tony?
Well, I know I ate 4 chicken wings last night, but if you ask me for the whole week, I ate chicken maybe one other time, but probably, I don't know.
I'm going to interrupt you. I rest my case.
Right. And that's just last week. And, epidemiological studies with food frequency questionnaires, they go back the whole year. I mean, it's a ridiculous idea that an epidemiological study, which is a food frequency questionnaire you get, would in any way be accurate, even with good intentions. I just think that would be difficult.
And the thing is that why does it come out 2% in its in favor of the intervention? Well, who knows?
Right.
The number is so small. I mean, the important point is you have to look at the biology. Statistics will not tell you anything except statistics. You have to interpret them. Now, heart disease is a big killer.
Mm-hmm.
But if you take 10,000 men and only look at them for 5 years, most of them are going to still be alive.
Right.
even though they're at risk. Okay, let's go to the
Interesting.
next slide. Yeah, now there's the odds ratio,
Yeah.
0.7. So 0.7 is the reduction. So you'd have to, take the reciprocal of that, which is what is that? 1.4 or something like that.
That's right.
Uh,
Interesting.
so 1.4 now would not be admitted in a court of law. It's too low.
It's too low.
And so I couldn't resist putting the next part in.
Yeah, that's right. Fair.
You got to look closely to see any difference.
That's right. And I think my colleagues are following guidelines and the headlines that may say you shouldn't eat meat without looking into the details, like this gentleman on this slide, because they don't have time to look at the details. And then they have to not only look at the details, but have the expertise to be able to interpret what they're looking at. And
I'm glad you asked me that. Let's go ahead and I'll show you something else. Well, this is just quoting Dahl and Hill. The next, exactly what we're saying. They didn't have to do statistics. Okay, they could eyeball it.
okay.
Yeah.
Wow.
Next.
So
the trial designed to bring the most rigorous statistical analysis didn't require anything. 36 out of 36, you don't need a calculator. Okay, the next slide actually is what you were saying.
Oh, wow. Yeah.
Here's the paper that said red meat consumption and the risk of type 2 diabetes. They had three different groups, and this is what they studied.
That's right.
And
That's
the
right.
results they got: red meat consumption, particularly processed red meat, is associated with an increased risk of type 2 diabetes. Now, we've got to ask, before you do anything, you got to apply common sense.
Yeah.
Because that's the first thing that the previous presidential report from Hill gave 9 criteria for when an association is causal.
Right.
But he made the point that they're not cut and dried rules. You don't know. Statistics doesn't give you a feeling for the strength of an association or what its biological character is. It just gives you a number. You have to use common sense. You have to understand the biology. The biology of type 2 diabetes is all about carbohydrate.
Right. But let me say this, doctor. This is the average consumer is gonna not have the biology knowledge that I have and you have. The average news network will certainly not factor that in. The average doctor is busy, and the average nutrition professional, average pharmacist, they're busy, so they're going to see the headlines that says that red meat consumption increases your risk for diabetes, and they're not going to. So even though what you're saying makes sense, it's like common sense says that glucose and carbs will raise. That's the real risk. So there's a little bit of a disconnect there.
Now, and that's true. The person who does the popular report from MedPage Today should be very suspicious. And the consumer should be very suspicious.
Right.
Now, the problem is we don't know everything. Maybe red meat is it. After all, there is the gluconeogenesis and so on. So you do have to look at the answer. And you and I will now look at the data. Now, you don't start from scratch. You can't test everything. But let's see what the data looks like. You see this, and it's ridiculous. I mean, what
Yeah.
you do in science. When I teach medical students and graduate students about presenting their work, I ask them, what do you think you're supposed to do in a scientific presentation? And I try not to do what's called Socratic dialogue because it's so annoying. But so I usually tell them, teach. You're supposed to teach. And teaching means making it simple, making direct. I mean, Einstein is widely quoted as saying, you don't want to make it too simple, but you got to make it simple. This is not simple.
No.
Okay.
Yeah.
This is a snow job.
Yeah. It's just exactly. Welcome to. Well, you're out east, and I'm in Chicago, and I can't see. I'm driving on the Dan Ryan, and
Yeah,
I need a new windshield, or I need somebody to clean that snow
well,
off.
that's the title on the.
Oh wow, you got snow. That's funny.
Okay.
That's
If you
funny.
see that, you should think there's a snow advisory.
Right. That's right.
Now,
Crazy.
the best statistical test is the eyeball test.
I like that. How could a highly trained scientist like yourself suggest such a simple approach? It's pretty amazing. So,
and here it is. If it looks like crap, it is crap, because what this shows you is that we have the information on the per capita consumption of red meat.
okay.
And in the course of this time, it's going down. And it's going down significantly. These aren't 2% numbers. And the red dots are the incidence of diabetes. They go in an opposite directions.
So we're eating less meat as a rule. I'm assuming this is the United States.
Yeah, this is red per capita red meat.
And the incidence of diabetes is rising. So the eyeball test is clear as day. You don't have to be a professor or a doctor to look at this graph and see that opposite direction. Amazing.
Yeah, well, I told this to the authors. I mean, I just recently wrote a letter and I said, what the data shows is not that there's a controversy, not that there's a complication, but you're wrong.
Right.
Incorrect.
Just not right.
So, but nonetheless, they did come to this conclusion that it's associated with increased type 2 diabetes.
Okay.
Now, what's interesting here is I just realized this when I wrote to him, is that Bradford Hill had a number of different criteria. He said it should make biological sense. In this case, it's marginal. It could make biological sense, but it's not likely. There should be a dose response curve, which, looking at their data, was marginal. But of course, the problem is that the absolute results they found were marginal. I'll show you that in a minute. But one of the things he said, which is very interesting, because he did this in the 1960s at Bradford Hill, he said, experiment. Sometimes you can actually get the data. And we don't do that so much. Epidemiology has steamed off into its own world. We had the data here. That mathematical correlation should never have been attempted.
Right.
We know it couldn't be right.
Wow.
So anyway, I'm going to run through this very fast. I just want to show you one of the things that I do, or I recommend, which is what clinicians are trained to do is to, well, for example, if they have a disease with an obvious symptom, they try to do a diagnosis. And what that means is determining what the likelihood is that the symptom has the disease, predicts the disease. And they usually make squares. So I don't want to snow anybody with a lot of numbers here, but I'll try to run through this quickly and tell you what I did in the end, because it would take too long to go step by step. So let's do what we do. Yeah, I'm going to make a box. And on the left-hand side, I'm going to put Q5 means they broke up the people into quintiles. That just means 5 groups of people according to how much red meat they ate. So Q5 is the high red meat guys, and the rest are the no red meat guys.
Gotcha.
Okay. Then on the vertical axis, I have the number of cases, and then the number of people that didn't get type 2 diabetes.
Okay.
So total is 37,000. Let's go to the next one. Okay. Okay. So let's do this step by step. What does this mean? I filled in the box, and I'm going to now interpret it for you. So first conclusion, there are 2,000 cases. So you just add up everybody who got diabetes. That some of them had red meat, some of them didn't. That was 2,000. Next is the high red meat people were 655. So that's like saying that those are the people who had the symptom but actually got sick.
Mm-hmm.
But the thing is that the incidence was not that good. So all of the people who didn't get diabetes but did test positive. In other words, they're big red meat eaters, but they didn't get diabetes. That's 6,000.
Mm.
So the predictive value is the number of people in the red meat group who got sick divided by the total number of people who ate red meat. And that's 9%.
It seems kind of small, just my eye tests.
Yeah, I mean,
Yeah,
that's not a big incidence of association between red meat and diabetes, but it's something, okay?
Wow.
It's not zero.
Right.
If you do the same thing with the lowest people in red meat, you get 4%. So you don't have to eat red meat to get diabetes.
Right.
And so what's the difference? It's 4.3%.
Gotcha.
That's the absolute difference. That's not much of anything.
Woof. Okay.
So the next thing is what they came up with is an odds ratio of in the ballpark of 1.4. Okay, so that's a lot less than 2. But they said that was a good enough association. But they didn't justify it. They certainly couldn't get into a court of law. And the question is, given what we found before, how did they even get that good a number?
Yeah, but even that's true. But if the standard is at least 2%, how could they then justify a lower number? I mean, that seems a little biased.
They just said that it's an association. How did they get away with it? Well, that's why we're here. That's what this slide talk is about.
Wow.
Now, one of the things is that the actual what they did is to correct for confounders. Now, what that means is that, you know, there are a lot of different things that could have caused the same association.
Right.
So, for example, if you say that people got fat on from eating too much carbohydrate, well, you have to make sure that the carbohydrate consuming people weren't eating a lot of calories. So you got to correct for calories. So you can subtract the effect of calories by seeing the correlation with the calories and then subtracting that. So they corrected this stuff by adjusting for age, because older people get sick.
Right.
And from alcohol, because alcohol may contribute to diabetes. By the way, before you go on, one of the things that's wrong with epidemiology is that it has a linear model. It assumes that if alcohol is a contributor, it contributes something, and red meat contributes something.
Mm-hmm.
But it's not like that. You can correct for being a drinker. What you can't correct for is the effect that alcohol has on your response to anything else.
Right.
So there may be a little bit of a risk in red meat, but if you're a drinker, that may be the whole story. And you can't correct from that with this model. But they also correct for cigarettes and smoking status and family history of diabetes and shirt size, and history of hypertension and the total calories.
All right.
One of the problems, though, dietary score, they make up these scores about. And
What's a dietary score? I don't even know what that means, but you know.
they correlate how much calories, how much fat, how much carbohydrate.
Mm-hmm.
It's all made up. It's
Right.
The score. One of the things is that one of the authors of this study, Walter Willett, pointed out, next quotation there, there's no difference between confounding and explanatory variables. What he means by that is there's no difference between subtracting the effect of smoking from red meat or subtracting red meat from smoking. Well, which is the more likely cause?
Wow. Very simple, but true.
Okay, let me tell you a little joke about these confounders. Okay, so the lady, the woman sees that calls the police because the guy across the street is exposing himself. So the cop comes and says, lady, that window is too high. I can't see anything. And she says, sure, where you're standing, but stand on this chair here and you'll see what I'm talking about. So if you have to do that much work
Right.
to prove that it's a problem, it's not going to make too much sense.
Wow. Very good point.
Okay, what is meta-analysis? Well, we can do this fast. Meta-analysis is where you take a bunch of these studies, which may not be all that good to begin with, and then you average them.
Yeah, but in my, like I said, I'll be studying after this, and they have suggested to me that is like one of the gold standards is to use this methodology. But I'm hearing already you're saying some of the studies that you're using in your meta-analysis may be flawed themselves.
Well, not only that, suppose you have two good ones. What are you going to get from averaging them? Or put it another way, if you could average experiments, no experiment would be really good.
Right.
Well, anyway, let's go to the next slide because it shows you. This was the blog post I had called "Meta-analysis is to analysis." Next, what metaphysics is to physics. It's not my joke. I got it. It's not real. Okay. Oh, this is interesting because what I did. You have to understand that I've been in science a long time, and as you pointed out, I worked in a number of different fields, including psychology, at least marginally. I never heard of meta-analysis.
Mm-hmm.
So I went back and I searched on meta-analysis, and it turns out that in 1970, there were no papers. Meta-analysis did not exist.
Wow. Didn't know that.
Next, in 1980, there were about 50.
Mm-hmm.
And this is a logarithmic scale. So remember, the logarithm is the exponent. So in 1990, there were 100. In 1965, 1995, there were 700. In 2005, next point, there were 1,000.
Yeah.
And then in 2014, there were almost 10,000.
Mm-hmm.
So it's going up by, in other words, this thing didn't exist and was invented by itself. It's what's called spontaneous generation. It doesn't mean anything.
But they thought they were improving science by coming up with this methodology.
I'll give you the bottom line. Okay, well, let me show you some of the data. Next slide. Okay, this is what's called a forest plot. It's somebody's name. But there's a line there, and you can see it gives you the averages, and the horizontal line is the spread of the data. So it tells you how bad the data is. So all this is bad data. Okay, but down at the bottom, it'll tell you what it is, because this is testing a drug that's a beta blocker. And if the data point is on the left of the line, it says that the beta blocker did better than the control. If it's on the right side of the one line, then the beta blocker did worse.
And this line is 1.0 is the line you're speaking of, right?
Yeah, so that's even odds.
Gotcha. Okay.
The statistical rule, next slide, is that if the error bar in each of these data, this is like whatever this is, 15 different tests, 15 different experiments, 15 studies. If the error bar crosses 1.0, it means there's no statistical difference. It is not statistically significant. Okay. Well, you can see they're all not statistically significant. There's only one that is. And yet they average this out. And this is the original 15 wrongs make a right.
Right.
I mean, it's utterly wacko. So the bottom line, though, I'll give you the bottom line, and then we can wrap this up. And this is the proviso about looking at meta-analysis. Next slide there. This is more snow job. I don't even know what that means.
Okay, let's keep going.
What this does show you is pointing out the two at the top are not statistically significant. In fact, all of them are not, except for one. There's only one. Wow. So averaging small, underpowered studies is a last-ditch Hail Mary analysis. That's what meta-analysis is good for. You know, you got a very small study, you got 10 subjects, you didn't really see anything, but somebody redid it with another 10 subjects. You average it, you hope, you're hoping that something will appear. But if you do a meta-analysis of large studies, and it shows that they're roughly consistent, if they go in the same direction, then what do you know? You know just what you knew before.
Right. You don't know. Right. I mean,
averaging them will give you more error. Not
right. Yeah, I think you're right. I mean, if I have 10 studies and 8 of the 10 say low carbs better for you, then I should be done. I shouldn't have to average them out to hear that answer, right?
Suppose they're not consistent. Suppose you got
right. I mean, then what do you do? Right. It doesn't. Do you think this is politically motivated? Because it seems like if I don't see the data I want to see, I may want to do a meta-analysis to prove something that doesn't really exist. I'm just trying to find more evidence.
Let me give you the punchline. Suppose the studies are different. Suppose they're not consistent. Suppose they go in different directions. Well, for that, I have the story on the next slide. Consider an emerging country building a railroad. Should they use a gauge to match the country to the north or the country to the south?
Gotcha.
And the answer is the parliament voted for a gauge that was the average of the two. What do you know?
That's, yeah, I mean.
Now, in terms of the motivation, I'm afraid that we have to invoke what somebody called Hanlon's razor. Hanlon's razor says, you should not invoke malice until you've excluded stupidity.
Wow. I hate to call my colleagues stupid, but I tell you, I just don't think, having heard your presentation, that it makes sense to use a methodology which is averaging things. And then the epidemiological argument where you send out surveys to people and you asked me about my chicken and I'm trying to figure out what I ate this week, let alone the last year. I think that type of science is flawed. And I think part of why I wanted you to talk on this subject is to help people understand that they can't trust the headlines and and that people are not being nuanced and they're not making decisions based on science, and they're just, they're scaring you. Not that their intent is malice. I don't know that, the local news is intentionally trying to skew your views, but common sense should kick in. The eye test should kick in, and the empiric experiences, and so I think all of that matters. And so I just wanted to say that out loud. And this last comment, meta-analysis can show consistency. Many small studies may point to something new if you're lucky. I like that. So that's that. So I really appreciate that presentation, because it really provided some wonderful insights for me. And I'm gonna stop sharing my screen here and get you back in there. And
okay.
Yeah, but the timing was perfect, because the slides, I commented on those slides, and because it wasn't much to comment, I just read the last bullet point. But this is exactly what I wanted this to be. I know it's a little scientific. You kind of blew my mind with the this clarifying the issue around meat and diabetes, because so many people are afraid to eat meat. But yet my carnivore colleagues, Dr. Ted Berry, Dr. Sean Baker, the Black carnivore, if you look her up, they're eating just meat, and yet there's no diabetes, there's no inflammation, there's no autoimmune disease, and yet we have this fear of animals. And then they say, well, you have to eat grass-fed, this and that, and that may be true. But even if you eat grass-fed and pasture raised, is the difference in the benefit significant enough to justify that? And I'm not sure it is. I try to do some of that.
It's not only is it significant, does it exist at all?
Right, exactly. And should I be spending? I go to Aldi's, even as a physician. I go to Aldi's, and I'm torn. Do I grab the grass-fed beef, or do I grab? And I'm paying a premium for that. Is it justifiable? And what I say to people,
my experience is that, I recently had some grass-fed beef that was very good. Usually the corn-fed beef tastes better. But the point is that if you're concerned about, if you don't want to, if you're concerned about killing animals, you shouldn't eat it.
Right.
But it's not a health issue.
Right.
And it's not, my guess is, an environmental issue, because the people who have the environmental story, are just emotional. They're just flying off the handle. But when I have to bring this message to medical students, I mean, it's a problem, because medical students want to know the state of knowledge. And
right.
They're not interested in, they're interested in an iconoclastic position if it's accurate. And this is what I ask them. Maybe this is a good closing statement. I ask them, do you think there's ever been a time in the history of medicine when the great majority of physicians and scientists held to an idea that was not only wrong, but was dangerous, and they denied the data? Do you think that's ever happened in the history of medicine? Well, of course they do.
Right.
So I said, well, if you think that's happened, you have to at least consider the possibility that this is another time like that.
That's right. And I think that we always can, if we're honest with each other, we'll say there's always bias in the world. So as a patient, as a clinician, we're all obligated to be skeptics and to always question things. That doesn't mean we don't trust anything, but it does mean that you use common sense. And if you have people in front of you who follow guidelines that have not yielded them a healthier life, they're still on their medicines, or they may be going higher on their dose of insulin, then you need to question that. You need to ask yourself, is this the best path moving forward? And that's one of the reasons why I came up with this nest and rope, because I wanted people to think beyond just nutrition, exercise, stress. I want them to think about all of those factors. And it may just be one factor. It could just be I'm in a dysfunctional relationship, which is why my blood sugars and my blood pressure is high. So I want to make sure people are thinking broadly. And then if you have a clinician who you're concerned about, and you want to stay with them, maybe you share this type of information with them so that they'll be able to think outside the box. Maybe you recommend The Big Fat Surprise by Nina Teichholz, a great book that shows us that meat is not the problem. Maybe you recommend Good Calories, Bad Calories by Gary Taubes, who clearly tells us that it's not necessarily about the calories. So I think that, and in the research you're doing, we're trying to figure out, is there a link between cancer and a dietary approach like keto? And I just appreciate that work you're doing. And I appreciate you taking time to help our audience think about science. I know it was a little scientific for some. Go back and check it out again, share it with those who may benefit, and understand that we're on a mission to just spread the word that for many of us in America, a carb-restricted diet is best. For those who are insulin sensitive, enjoy your carbs, but for many of us who struggle with weight, chronic metabolic diseases like heart disease and polycystic ovarian disease, and the list is long. We need, think about it, type 3 diabetes is now what they call dementia. So, Amy Berger's book, The Dementia, The Alzheimer's Antidote. We're starting to learn that metabolic disease is potentially the cause of many things. The good news is that we don't fix those things with, your medicine or the surgery. We fix it with diet. So as you think about protecting your nest personally, me and the professor is going to do the same. Always remember that all of those principles are the way you can get to a healthier life. So as we kind of wrap up this session, Doc, is there any two things, final comments, and how does this audience get to see more of your work, rather through your books or the research you're doing?
Yeah, well, like I say, the book's on sale, or you can buy Ernährung im Faktcheck. That's the German edition. A new German word, Faktcheck. So German has adopted a large number of English words. But there's a lot of information on the internet. And really what you're saying, you have to be skeptical. Yeah. I mean, you have to ask yourself, does it make sense? And you can challenge the experts. You can actually write to anybody.
Yeah.
You can write to me. You can write to the people who do the research. If you're polite and constructive and serious, they'll answer you if they can. I mean, if there are people who are too busy to answer random letters, but you don't know.
That's right.
And
repeat the title of your books so people can kind of look for it.
My assistant will send you the information on how you can get it for, I don't know, $6.95 or something.
Okay. We'll put that in the comments, or should I say the show notes, and I'll put that on both Facebook and YouTube. And then for those who check out the podcast.
Oh, and here's a good deal. If you donate $50, tax deductible to the extent of law, I'll send you a autographed, personalized copy.
Nice. I like that. And I do think that I really, again, appreciate we need science, guys. So we want to support, if you have a personal success story, or if you understand the value of us doing science in the world of nutrition, again, recognize that a lot of the research in nutrition doesn't happen because there's no drug to create. So the profit incentive is not there. So definitely support Dr. Feinman's research. So with that, I want to thank you again for both the podcast and for the post podcast. We spent a lot of time together on a Sunday. For those who listen to this or see it later, it's a Sunday In Chicago, it's around noon. I'm going to go and eat my the beef I have today was not grass fed, so thank you. So I'll enjoy that, and I appreciate your time. For those who are listening, thank you for being here with us today. And as I always like to wrap up my sessions, continue to protect your nest and the nest of your families. Everybody have a great Sunday, and we'll chat again. Thank you.